All right, welcome to our high-yield masterclass on atherosclerosis. Today, we are going deep, and I mean deep, into the life story of an atherosclerotic plaque. Now, I want you to forget the old, tired, clogged pipe analogy. It's wrong. We're going to explore this for what it truly is, a dynamic, chronic inflammatory disease. This whole session is built for board mastery, giving you the framework you need to absolutely crush any question on the #1 killer in the modern world. Let's get into it. So here's our game plan for today. First, we're going to build a rock-solid foundation by sorting out the different types of arterial hardening. Then we'll trace the entire life of a plaque, from the first little spark all the way to a complex fibroatheroma. Next, we'll learn to spot the ticking time bomb, the vulnerable plaque, and look at the two catastrophic ways it can blow up. And finally, we'll wrap it all up with how we manage this in the clinic.
Okay, first things first. Using precise language is what separates the top scorers from everyone else. You see, arteriosclerosis is just a big umbrella term, and you can bet your exam will test you on the 3 distinct types that live under it. So let's nail this down right now.
This right here, this is our main event. Atherosclerosis is a disease of the tunica intima. That's the innermost lining of our big and medium-sized arteries. I want you to think of the intima as the battleground. It's where this whole story is going to unfold. The hallmark lesion is the atheroma, and it can do 3 bad things: narrow the vessel, rupture and cause a clot, or weaken the wall and lead to an aneurysm.
Next up, we've got arteriosclerosis. The keyword here is arteriole. This affects the little guys, the small arteries and arterioles. For your exams, I want you to weld this term to 2 major diseases: chronic hypertension and diabetes. That's its fingerprint. It comes in 2 flavors: hyaline, which you see in milder hypertension and diabetes, and hyperplastic, which gives you that classic onion skin look in malignant hypertension.
And for our third type, we have Munkenberg sclerosis. Now, this is a classic exam question favorite because of one, and it's a huge one, crucial difference. See, the calcification here is in the tunica media, the middle muscular layer. And here's the high-yield point you absolutely cannot forget. It does not narrow the lumen. The vessel gets hard, sure, they call it a pipe stem artery, but the blood flow is fine. That's why it's usually just a, hey, what's that, finding on an x-ray.
Okay, now that our definitions are locked in, let's get to the main story, the biography of an atherosclerotic plaque. We're going to break this whole thing down into 5 clear, step-by-step stages that will take us from the very first insult all the way to a mature, complicated plaque.
Think of this as a 5-act play. Act 1, endothelial dysfunction, the trigger. Act 2, lipoprotein retention. The bad guy, LDL, gets trapped. Act 3, foam cell formation. This is where inflammation really kicks in. Act 4, smooth muscle cells try to wall it off and form a cap. But then, Act 5, things can get nasty with the formation of a dangerous necrotic core. This whole sequence, that's the response to injury hypothesis in a nutshell.
So here's a really critical point. How does a macrophage turn into one of those lipid-stuffed foam cells? It's all about the receptors. Now, you know the normal LDL receptor has a feedback loop, right? Well, macrophages use different ones, scavenger receptors like SRA and CD36. And here's our memory anchor. I call them the no-brakes receptors. They have no off switch. They don't get downregulated. This lets the macrophage just gorge itself on oxidized LDL, becoming this bloated foam cell, which is the building block of the early fatty streak. Okay, micropause. Just take a second. Picture that macrophage. It's like an overeager cleaner that literally doesn't know when to stop eating.
All right, the story is about to take a dangerous turn. You see, a plaque can just sit there for decades, growing quietly. But then it can transform from a stable lesion into an unstable, vulnerable plaque. This is the one responsible for the vast majority of heart attacks. Let's learn how to spot this ticking time bomb.
Before we define it, let's do a quick recall check. As a plaque gets bigger, the artery often remodels outward to keep the lane open for blood flow. What do we call that process? And, more importantly, why is it so incredibly dangerous? I'll give you a second. The answer is positive remodeling, or Glogov remodeling. And it's so dangerous because it allows a huge, unstable plaque to grow without causing a single symptom. The patient feels great, their stress test is totally normal, right up until the moment it ruptures. So this slide lays out the 4 cardinal features of a vulnerable plaque, which we also call a thin cap fibroatheroma, or TCFA. You've got a thin fibrous cap, a big, mushy necrotic core, a ton of inflammatory macrophages crawling all over the place, and it's probably undergone that positive remodeling we just talked about.
This is a battlefield where the enzymes from macrophages, the ones that chew up collagen, are winning the war against the smooth muscle cells that are desperately trying to hold that cap together.
If you remember one single number from this entire section, I want it to be this one: less than 65 micrometers. This is the critical number for plaque vulnerability. Autopsy studies show us that something like 95% of plaque ruptures happen when that fibrous cap thins to below this exact threshold. This is the breaking point. You have to memorize it.
We've now reached the end game. A vulnerable plaque can cause a heart attack in one of two ways. For years, all we talked about was rupture. But now we know there's another major pathway: erosion. And knowing the difference between these two is absolutely key for your exams. Let's make this clinical. Picture two patients rolling into the ER, both having a heart attack. Patient 1 is a 72-year-old man, classic risk factors. Patient 2 is a 48-year-old woman, a heavy smoker. Now the final outcome is the same, a blocked artery. But the mechanism that got them there, probably completely different.
And this slide just lays out the contrast perfectly. Plaque rupture, that's probably what happened to our 72-year-old man. His thin cap fibroatheroma literally tore open, exposing all that thrombogenic gunk in the core, and he formed a big, red, fibrin-rich clot. Plaque erosion, on the other hand, is the likely culprit in our 48-year-old female smoker. Here, the fibrous cap is actually still intact, but the surface endothelial cells got stripped away. This leads to a white platelet-rich thrombus. This distinction is ultra high yield.
So, knowing all this amazing biology, how do we actually fight back? Well, modern management has shifted. The goal isn't just to lower some numbers on a lab report anymore. It's about changing the plaque's entire biology, stabilizing it by calming the inflammatory fire inside the vessel wall.
To help you remember who needs a statin, let's use another memory anchor. I want you to meet the 4 statin sisters. First, there's Vascular Victoria. She's easy. She already has known atherosclerotic cardiovascular disease. Next is high LDL Helen. Her LDL is way up there, 190 or higher. Then we have diabetic Dan, who is between 40 and 75. And finally, there's risk factor Rita. Her calculated 10-year risk is 7.5% or more. If your patient is any one of these sisters, they are in a statin benefit group.
Okay, time for a massive exam trap. Exam trap number 1. A coronary calcium score of 0 is fantastic news, don't get me wrong. It gives you a great warranty period. But do not be fooled into thinking it means there's no risk. A calcium scan only sees hard, calcified plaques. The most dangerous, vulnerable, ready-to-rupture plaques are often soft, non-calcified, and completely invisible on that scan. And here's another classic board trap. You get a question about a patient who just had a heart attack, and it asks for the next best step. The answer is always, start a high-intensity statin. Don't fall for the distractors like, check liver function tests first. Unless the vignette is screaming active liver failure, the immediate, life-saving move is to start atorvastatin 80 or rosuvastatin 40, period. And this really is the ultimate takeaway. This is modern cardiology. We have moved so far beyond simple plumbing. The goal isn't to just unclog a pipe. It is to fundamentally change the plaque's biology, to put out the inflammation, to thicken the fibrous cap, to shrink that necrotic core. We are literally transforming a hot, inflamed, vulnerable plaque into a stable, scarred, and quiet one.
And that concludes our masterclass. Now, to really lock in these high-yield concepts for your exams, make sure you access the resources attached to this explainer. You're going to find a set of crisp, high-yield PDF notes and a full-colored mind map that is absolutely perfect for quick revision and spaced repetition.